It's an interesting topic, the next one. What if there is still a residual disease after these all methods of treatment? Next speaker will be Professor Greta Dreyer, speaking about surgery in locally advanced and residual disease in post-concurrent chemoradiotherapy.
Good afternoon, everyone. I also want to start by thanking the organizers for inviting me. It's also my privilege to be here representing also the IGCS, and it is a real privilege for the IGCS to work with MEMAGO as a combined strategic alliance. So I would like to shift gears now from the immunotherapy, chemotherapy, thinking only about the medical things, towards a real surgical topic. And I want to actually start my topic by talking about surgery for locally advanced cervical cancer as an alternative to chemoradiation. But let's move on first to the outline of my talk. And first want to actually challenge the idea that so many speakers before me has completely accepted, that chemoradiation is the standard global approach for locally advanced cervical cancer treatment. I think there's also a big question about how we define locally advanced cervical cancer, and most definitely 1B3 is not the same thing as 2B, but very often they are lumped into the same trials. So we need to decide what are we really talking about here. Then I would like to talk about the primary surgical treatment versus then chemoradiation and where that takes us. And I'm going to completely skip the neoadjuvant chemotherapy debate because that has been done. So if we talk about the globe, I think the globe is very difficult. And I say this also from an IGCS perspective and from my own perspective as a South African, where we have a huge HIV prevalence and epidemic, I can call it. And from my perspective as an African, where we have so many women with cervical cancer, almost all of them present with large tumors, and we have so few radiation equipment and so little really to offer these women. And let me add, very, very little immunotherapy and very little access to all these fancy treatments that we are now sort of accepting more and more as standard of care. So if we say, is this the standard in the globe, I think we also need to take note of published series, retrospective, from other areas, like the Korean one, where they say that if we retrospectively look at what has happened in Korea in the last 10 years, the standard treatment for 1B2 cervical cancer is actually radical hysterectomy. Second to that, it's neoadjuvant chemotherapy followed by radical hysterectomy. It is not concurrent chemoradiation, which actually followed only as a third option. I also think that when we look at the historical comparison of primary surgical therapy with the outcomes of chemoradiation therapy, we need to accept and understand and maybe be reminded that in our own continent, very, very few people will actually get what is considered optimal chemoradiation therapy or even optimal radiation therapy. Number one, starting as soon as possible, finishing within 43 days, getting the correct dosage, etc., etc. And it is only when we follow all of those prerequisites that the outcome is great. And if we cannot follow it, then we need to reconsider primary surgical therapy for these patients as a very real option. I also think that the very interest that we've shown in this session in neoadjuvant chemotherapy to make more people operable again, the interest that we show, that we've seen in actually reducing radicality for smaller tumors, and also the interest in the cost efficacy of primary surgical therapy when compared to chemoradiation therapy, all points towards us having to rethink the paradigm of actually chemoradiation therapy as the completely accepted global standard for large cervical cancer tumors, or I would say bulky early stage. So what is the quick literature overview of this point, of this debate? We know that randomized controlled trials in the past actually showed no difference in survival between surgery and radiotherapy. And we also know that later trials actually showed that radical hysterectomy followed by tailored adjuvant therapy has actually better survival outcomes. But these are mostly retrospective, and we know that there is selection bias. We also know that about 30%, and it depends on what your radiation or your adjuvant therapy criteria is, but we know that about 30% of patients with large early stage tumors or bulky early stage tumors will actually not need adjuvant therapy, which means that if you really have a problem with your radiation resources, this is a way to actually save some radiation resource. I've already talked about the cost effectiveness debate, which is ongoing, and I think in all, it actually says that radical hysterectomy plays a significant role and continues to play a significant role in patients with these tumors. Just looking back a little bit about the true reasons for accepting this as a standard, and I don't want to stir too much, but I want to stir a little bit, because I think that the equal outcome but higher morbidity due to dual therapy is a bit of an ancient idea, or a bit of it's really based on historical data, and the IMRT option will definitely for most patients lead to a very much lower morbidity from dual therapy. Also, if we say that dual therapy is so terrible, we should reconsider what are we really doing by adding neoadjuvant chemotherapy before surgery, because that in itself is actually dual therapy. And we know very well that neoadjuvant chemotherapy followed by radical surgery has a higher morbidity than radical surgery on its own. So we need to really also consider, as I said, the fact that resources are not equal across the globe. I think there may be a bit of a power struggle between surgeons and radiation therapists, and that especially in a historical way. And then I think also that people need to reconsider patient preference, because there's very good data that if you ask a patient, she would almost always prefer having the tumor removed. And if we really have equal outcomes for the two arms, then we should consider patient preference. There's also then data from this Korean retrospective study that I already referred to, and they have shown very definitely that there's no statistically significant difference in the overall survival and also in the severe adverse events, with a trend to the positive. Same with the study by Park et al. And here, this study actually has a strong trend towards an improved progression-free survival, and with the only real important limitation that it is a retrospective study. The concurrent chemotherapy had more tumor recurrence and more death than the primary radical hysterectomy arms. Why am I saying so much about this? Because I do think that if we consider the surgery after concurrent chemoradiation therapy, we need to actually think about the alternative treatments. And I will show you that currently surgery after concurrent chemoradiation is not actually a great option, which means that we have to rethink what do we actually have to offer to really prevent local recurrence or local persistent disease. Just want to show you that in this Korean study, interestingly, and I don't know if you can read this, but actually in the retrospective study, the excellent outcomes were in spite actually of about 40% of patients having positive parametrial and positive lymph nodes in the surgical group. Now, it does also point towards the limitations of imaging, which I think most of us understand very well. And those are the survival curves with clear superiority of surgery in this trial. So that takes me then to what is the role then of surgery in locally advanced cervical cancer patients, however we define that, after chemoradiation therapy. And I'll talk about patients with or without residual disease, and also then as surgery as an alternative to brachytherapy, because I do think there is a real need to have an alternative for brachytherapy in our continent, and about the difficulty to diagnose residual disease after radiation. So first, I want to talk about the surgery as an alternative to brachytherapy, and I think the trial by Cetina in 2013, published in 2013, is the best one we have here. And they have shown that surgery can really make up for the absence of brachytherapy. And we know that the local recurrence rate, if in the absence of brachytherapy, is actually unacceptably high. And there are many, many places in our continent who do not have the opportunity of brachytherapy. However, while we can make up by removing the cervix, the surgical adverse events is actually really very high, and it is therefore absolutely not the preferred treatment. Brachytherapy has much better data than that. But I think the study did show that it is a feasible alternative, paying the price that you pay. So there are some remaining questions still, and that is number one, patient selection. And we do know that there's a very high recurrence rate, even if these patients are pathologically complete responders. It is a question whether you should actually offer it to everyone or only patients with positive pathology after the initial external beam radiotherapy. The other question is what type of hysterectomy should you offer, and whether the lymph nodes should be resected or not. Now, if it is just an alternative to brachytherapy, it does not actually make any sense to do lymph node dissection, so most probably not. So what about the data that we do have about doing surgery as so-called completion therapy after patients with a complete response? Philip Maurice's study is actually, I think, the best one that gives us data about this. His design was 61 patients with in a randomized controlled trial, 13 each arms, with hysterectomy or not, and actually then included only patients with a bulky early stage and a stage 2 tumor, because those were the only ones I think that are considered surgically resectable. Now, even in this trial, which was actually designed to answer the question about complete pathological complete responders, still 10 out of 30 or 33% of patients had positive histology on the final hysterectomy specimen, pointing to us already to this question about how do we define complete response on radiation. They still had a 20% recurrence rate, and they had 12 to 15% positive nodes of the chemoradiation therapy. And this really is the issue also with the relatively high recurrence rates of the primary chemoradiation therapy in late stage. And here we don't have stage 3 and stage 4 in this trial, even that will even be higher. Interestingly also, and I think this is important for us to take note of as clinicians, the persistent disease and the recurrent disease and recurrent nodal disease was all completely missed on the imaging after chemoradiation therapy. So we do not have good modalities to actually predict this. What if we look at the whole complete group of locally advanced cervical cancers who had chemoradiation therapy, and not only the ones that we consider as complete responders? There are actually quite a few studies. This meta-analysis by Shi included 8 studies, 2,000 patients. Both radiation therapy and chemoradiation therapy were included. And they then specifically looked at the hazard ratio for overall survival. And in these two groups, after adding all those 8 good studies, they actually had an overall survival, which was similar whether you did a hysterectomy after chemoradiation or not, with a hazard ratio of 1.13 and a confidence interval crossing 1. They considered the meta-analysis actually very good, and they also said that the studies were very homogeneous, so I think that the answer is that surgery plays no role as completion therapy for everyone who has completed chemoradiation therapy with brachytherapy. So what about this retrospective British service analysis? I don't think the study adds actually much to our knowledge, but it's published also by Platt in 2018. They included 15 patients only. That's the only ones they could find in 4 years, and they actually had no real significant finding other than to say that MRI was inaccurate. So just to say how difficult it is to actually diagnose residual disease, and in this retrospective multicentric study by Heckert, the design of looking at 160 patients, the vast majority that was 2B or less, they had a residual tumor size of larger as 1 centimeter, showing that there was a much, much worse disease-free interval. But interestingly and importantly, the MRI was significantly false positive and false negative on both on this trial. So in summary and in conclusion then, the surgery as an adjuvant or a finishing treatment or a completion treatment really is feasible, but as a whole is not beneficial if we look at the total group. The surgical morbidity is much higher than with primary radical hysterectomy, and the diagnosis of persistent disease is very problematic. The theoretical benefit is probably highest in patients with the largest residual disease, but we also have a problem because those patients have a very poor outcome whatever we do. And the subgroup that will benefit most from this approach has then unfortunately not been defined. My conclusions about primary surgery is that it has at least a similar outcome to primary chemoradiation therapy. It actually potentially saves radiation in about 25% of women. The morbidity of dual therapy, in my view, need to be re-evaluated in the age of new technologies. And then I think also the comparison in outcomes and cost of the two modalities need a re-evaluation as well. It is definitely in surgery after chemoradiation is a feasible alternative to brachytherapy, but at a higher morbidity cost. I do think that the poor outcomes of our salvage strategies for residual disease after chemoradiation therapy highlights the role of primary surgery to obtain local control in patients with operable disease. Lastly, complete radiation response in residual disease difficult and inaccurate to diagnose. Surgery as completion therapy is actually not beneficial in terms of overall survival, and the outcomes of large persistent disease is unfortunately poor in spite of whatever we try. I thank you.